All right, welcome to Partners in Pancreatic Cancer. I'm Dr. Bekaii-Saab. Today I would like to discuss the best sequencing approach for second-line therapy when using FOLFIRINOX in the first line. FOLFIRINOX in the first line is indicated based on a large phase 3 study comparing it to gemcitabine. FOLFIRINOX, and as we use it primarily in its modified form, getting rid of the bolus 5-FU and the leucovorin and cutting down on the dose of the antican often in some regimens, despite the modifications, tend to be quite a tough regimen in most patients. But its level of benefit, at least according to the published studies, tend to be quite significant over gemcitabine for this disease with very few options. The limiting factor with FOLFIRINOX in the first line is that second line therapy is difficult to define, as there is very little data, prospective data at least, with gemcitabine based regimens, specifically gemcitabine and nab-paclitaxel, but there is certainly some retrospective data as well. And the prospective data tends to be very limited, very small, and there are very few attempts to study the question. Another challenge with FOLFIRINOX is the toxicity, the neuropathy that can arise because of the oxaliplatin, and then the implications on the utilization of nab-paclitaxel, which has its neurotoxic potential following FOLFIRINOX with a platinum-based compound. So for those patients who go through FOLFIRINOX, have very little toxicities, do not have any residual neuropathy, gemcitabine and nab-paclitaxel may seem as the natural fit for second line. For those patients who may have had a tough time with neutropenia, who may have some significant neuropathy, may want to consider gemcitabine and capecitabine. In this group of patients, a bi-weekly regimen of gemcitabine nab-paclitaxel would be significantly preferred, given the fact that the toxicity is lesser, and it's more likely that those patients will be able to tolerate an every other week regimen than a weekly regimen. And so for the majority of the patients who are still able and capable to get chemotherapy in the second line following FOLFIRINOX failure, my first choice would be bi-weekly gemcitabine and nab-paclitaxel, and then second choice would be gemcitabine plus, say, capecitabine or other therapies, especially in the presence of residual neuropathy. Thank you for viewing this activity.